All right, so sedation overview. So just like with pressors, we had beta 1, beta 2, alpha 1 receptors. We had vasopressin 1 and vasopressin 2 receptors. We had dopamine receptors. We had angiotensin 2 receptors, technically called angiotensin 1 receptors. But we had all these receptors for cardiac, right, for vasopressors. And also, on the flip side, for ones that we're going to inhibit with vasodilators for hypertension. It's a very similar thing with patients that have, with sedation, right? With sedatives, we need to know about GABA receptors. That's our homeboy right there. That's usually the one that's going to be inhibiting stuff, right? So GABA receptors by default, right? GABA receptors by default are inhibitory, and they have like 5 different receptor sites, right? They have like they have 2 alpha, or have 5 alphas, they got 3 betas and 2 gammas, right? So we don't have to know every single one. We just need to know that they either block it or they don't block it, right? So GABA itself is inhibitory, so it's going to inhibit the brain. So if you have a GABA agonist, means it's attaching to a GABA receptor, it's going to inhibit the brain in some fashion. How does it inhibit it? Well, it's going to cause anxiolysis. It's lysing anxiety. It's taking away anxiety. It's causing anesthesia. What's anesthesia? That's without thesia, or thesia is pain, right? So it's fixing pain a little bit. Some of them do, some of them don't. Like Propofol and Versed or Benzos don't cause anesthesia. All right, amnesia makes you forget, right? And then addiction is another possibility. Someone's on a GABA agonist, they can be addicted to it, right? Cause it suppresses depressive moods, it suppresses seizure activity, right? And it causes, I can't think of the word that starts with A, it starts with relaxation, right? So it causes you to be relaxed as well. It's going to relax them a little bit, right? And then lastly, which is more important, is apnea. So it causes respiratory depression, right? They can't be on this medication without a ventilator in place if it's an IV infusion. If it's an IV push, we can maybe get away with it and monitor them, right? That's called conscious sedation, right? But notice what's not here is analgesia, right? There's no analgesia that happens when you give a GABAergic, right? So Propofol is a GABAergic, right? So Propofol down here is a GABAergic, right? Midazolam are PAMs and LAMs. Those are all our benzos. Those are all GABAergics. They all bind to these receptors in some fashion, and they're going to block they're going to block these pathways, which is what GABA does to begin with, right? It's an inhibitory neuron, and it's going to go into the brain and go to all kinds of different pathways and inhibit them in some fashion, okay? And then we have NMDA receptors, right? And these are NMDA receptor antagonists, because NMDA is excitatory, right? When you bind to a NMDA receptor, it's going to excite things. It's going to cause neurodegeneration and excitotoxicity, which is not great, right? Like ALS is a upregulation of these receptors, for instance, right? It causes degradation of the nerves of the spinal column, or excitotoxicity in general in the brain could cause degradation of these pathways that we want to avoid, right? That's why chronic pain is a situation, or chronic anxiety, etc., can cause more issues down the road. Right, so we have antagonists, and ketamine is usually our go-to one, right? That's our NMDA antagonist. That's legal, right? There is such things as LSD and such that we can use, but those are not going to be, those aren't a medication you give in the ICU. But ketamine is, right? And ketamine is going to be blocking these receptors. Therefore, it's blocking the excitation. So that means we're causing some sedation, right? Also, NMDA causes pain, so if you give ketamine, it's going to block pain, which is nice, right? So it's going to block these excitatory pathways that were upregulated or utilized when you had NMDA activity, right? So ketamine blocks all that NMDA activity. And then we have opioid receptors, right? So those are different kind of receptors found in the brain. They're also found where else? Outside the brain. They're also found in the GI tract, right? So if you bind to an opioid receptor in the GI tract, it's going to cause peristalsis, right? Or it's cause decreased peristalsis, I should say. It's going to cause a ileus, or paralytic ileus is possible when you attach to an opiate receptor, right? There's 3 flavors of opiate receptors, mu, delta, kappa. I'm sure there's probably med school somewhere where that's their brotherhood name, all right, or their fraternity name. But either way, we have we're going to bind to these receptors, and opioid receptors are inhibitory by default, right? They inhibit pain, right? They inhibit respirations as well. That causes you to get apnea, causes anesthesia, right? That's their primary role, right? We don't usually give opiate blockers. We give opiate agonists, right? They bind to the receptor, and they do what that receptor normally does, right? So we got fentanyl, we got hydromorphone, and morphine. They all have different levels of activity and levels of, not virulence, but potency. Okay, and then if we bind to the gut, right, that can cause the gut receptors, that can then cause us to have really bad constipation to the point of ileus, right? That's one of the considerations if you have someone that's getting a IV opiate infusion is, when's their last bowel movement, right? Because it's been 3 days, it's like, well, that's a problem. Why are we still on fentanyl at 2 mics or 3 mics even, right? We should have been cutting that down to something else for pain management. All right, then we have dopamine receptors. Dopamine receptors are excitatory, right? They get activated, and if you activate them, it causes you to get what's called hallucinations, but also and psychoses. But also we have what else? If you activate them, it's going to cause vomiting, right? So also going to cause prolonged QTs. So why do I mention this? Because we are going to give medications that are blocking agitation pathways, right? And these certain medications are blocking dopamine pathways, such as our typical and atypical antipsychotics. We've got haloperidol, for instance, quetiapine, olanzapine. These medications that are blocking dopamine, right? They're not dopamine agonists, they are blocking these symptoms. All right, then we have alpha-2 finally. So alpha-2s, these are agonists, so they're binding to the alpha-2 receptors. We know that norepinephrine, when it gets released from a neuron, it's going to go to the other neuron on the other side, and it's going to cause a release. It's going to cause SNS activity, right? So norepi gets released, and it causes SNS activity. We know that happens, right? It's going to raise our heart rate, raise our respiratory rate, raise our agitation and anxiety. In the brain, it causes a lot more agitation, right? So it causes a increased agitation, increased pain. So it makes sense that, hey, why don't we just stop it in the first place, right? And we have little alpha-2 receptors right on the outside here that we can inhibit, right? Little off switches for the SNS, right? Because norepi gets released, and the way it knows it released enough norepi is it self-regulates itself, right? So we're going to, partake in that, and we're going to give something like dexmedetomidine to inhibit that norepinephrine receptor. Okay, so dexmedetomidine, clonidine is just the PO form of that, right? If you're trying to get someone off an IV infusion, you can start them on clonidine as long as they have a good what? QT? No, not so much. Good heart rate, right? So the heart rate needs to be elevated because we know if we block the SNS activity, we're going to have bradycardia, right? And we're going to have hypotension, right? So hypotension is usually, we've got a little hypertensive patient that's agitated. Clonidine PO is great. It's definitely going to, cause a little bit of sedation as well. It was actually designed as a sedative first when they developed clonidine back in the early 80s. Okay, and the nice thing is these do not cause respiratory depression, right? They have no effect on GABA pathways or other pathways that would cause a depression in their respiratory centers. Okay, so each one of our sedatives, we'll take a slide too. All right, so dexmedetomidine is the best thing since sliced bread, right? So it's a great medication we can use to control not only sedation, but also analgesia, right? So it's an analgesic sedative, right? And those are always our go-to agents. Those are things we want to be utilizing. All right, it's non-narcotic. It works on those SNS pathways, right? So we've got SNS activity over here. We've got norepi being made and packaged away, ready for that signal from the brain. The brain's like, hey, I need SNS activity. It's like, no problem, say no more. I release norepinephrine across the cleft there, and it's going to go ahead and inhibit itself so it doesn't release too much, right? And then what do? We tap into that. We just give Dex and say, hey, I'm just going to go ahead and stop that altogether, right? So we're going to stop SNS activity. Therefore, we get a bradycardia, right? You get more AV blocks, right? You can get some hypotension as well. Okay, so it's an alpha-2 agonist, right? And it works centrally. It doesn't work peripherally like some of our other agents that work like there's some other antihypertensives that work peripherally on the actual vessels themselves. This works all the way in the brain. That's where it's operating, all right? It can cause unexplained fever, which is we've had that happen a couple of times. We had it happen when someone gave too much Precedex, right? They gave like three bags within 4 hours, and the patient started developing fevers. It's like, well, that's because that is a side effect that can happen from Precedex as well. It can exhaust all of our neurotransmitters. They can get a tachycardia or a hyperpyrexia that develops. Okay, but it also develops what's called tachyphylaxis. And what's tachyphylaxis again? It's after 24 hours of use, right? So it's great for 24 hours, and then after that, it starts developing a tachyphylaxis. Not a tolerance, but a tachyphylaxis. So dose 1 1.5 is usually our max right here, right? It's going to press to 1.5, they're super crazy, right? And then next day, 1.5 is still infusion, and they're getting crazier. And you still get 1.5 the next third day, they're still crazy, right? Or even crazier, right? So Precedex is only good for about 2 days, 3 days at the most, and then it's going to start causing a decreased efficacy because patients develop a tachyphylaxis to it, right? You want to say tolerance, but tolerance means you require 0.4 for the same effect, and then 0.8, and then 1.2, and yes, that kind of overlaps a little bit, but this is basically, it develops rapidly, whereas tolerance develops over weeks to months. It's usually a receptor problem, whereas a tachyphylaxis is usually due to the medication property. Okay, so bolusing sometimes not recommended, but we can bolus it. We're going to start at 0.4 and titrate by 0.2 after 1.5, right? So how do I get to 1.5 from going by 0.2s? I don't know, but sometimes you get there. Okay, so usually you hit 1.4, you say, oh, I can only go by 0.2, I got to go up to 1.5, right? And then, like I mentioned, pioclonidine is IV dexmedetomidine, right? So it's the same exact agent. They do the exact same thing, right? So there's different, potency of the medication, but it works on alpha-1, alpha-2 receptors in the brain, right? And if we inhibit those, we're going to get bradycardia, we can get some hypotension and such, but that's exactly where dexmedetomidine is working, okay? So do not give with paralytics, and why is that? So it's non-amnesic, so it doesn't cause you to forget things, but also it's going to keep you awake and alert and calm, right? It's really hard to be awake, alert, and calm and paralyzed. That's a really difficult thing to achieve. So we want to make sure that we are not giving this with paralysis, right? It's not going to cause a deep enough sedation that we require with paralysis. Okay, so Propofol is one of our great agents as well, but here's our dexmedetomidine. And that's the one that we're going to be, that's usually our go-to agent for, has a lot of great things, but it's also really great on the end of our ventilator journey when we are weaning someone, because we can use it on someone who is extubated. Why can we do that? Because it is what? It's a non-narcotic, right? So it doesn't cause respiratory depression, which is going to be great. It's going to just work on the agitation piece. It's not going to work on suppressing respirations, which other medications like Propofol do. Okay, and also it's great because Propofol has no pain management, but Precedex does, which is nice. All right, Propofol. So Propofol is great for neuro patients. All right, neuro patients are, they are classic. You want to get you want to get a good exam on your neuro patients. You want to be able to say, hey, this is exactly what they're doing neuro-wise, right? Precedex, yeah, it doesn't cause that suppression of the neuro exam, but the Propofol is for your patients that do have a higher ICP or needs to be interrupted so we can get a great neuro exam at least every 4 hours or once a shift, right? So it's a very, very short half-life. That's why it's good for neuro patients, right? You turn it off, 15 minutes, absolutely, that's exactly what they're doing underneath that Propofol, right? So ICP is like 10, right? They're like, oh, I don't know, but you can back it off to get a controlled exam, especially with a neurosurgeon or neurologist there, right? And otherwise, the reason why it's good in neuro is because it's anti-seizure, right? It works on GABA receptors. We know we give benzos for seizures, so Propofol is just it's kind of like GABA, right? It doesn't bind to specific parts where GABA does, it binds to other parts of the GABA receptor. GABA receptor, again, remember, has like 7 different sites on it, right? Barbiturates can go there, Propofol can go there, and our benzos can go there. They all block it in some different fashion, right? Different areas of the GABA receptor. But we know if we bind to a GABA receptor, are we going to have pain management? No, these don't cause GABA receptors don't cause a reduction in pain. That's not their thing, right? Their thing is to reduce seizure activity, reduce wakefulness, right? They are going to suppress respirations. So can you give this after extubation? No, right? So the only one we can give after extubation is dexmedetomidine, maybe ketamine. That's a little gray area. All right, and low doses might be okay for ketamine. Either way, we can't give Propofol IV push in California. That's not a thing. They don't allow us to do that. So you might have someone, a provider from a different state or a provider that says, go ahead and give Propofol IV push. You can't do that, right? Then you are now being Michael Jackson's doctor at that point, right? So that's not okay. You want to make sure that we are, sometimes you can do it under their direct direction or direct supervision. That's okay. Or they're in the room and say, I'm going to monitor the Propofol administration. The idea is that someone will give it IV push and walk away, right, as an RN. So if you're right there with the provider, right, they don't have to like hold your hand and like give you a pat on the shoulder. You did a great job. They can be right there with you as you give it. Okay, so it has no analgesic properties, no analgesia, works on those GABA receptors, causes a dreamless sleep. So sometimes you'll catch a nurse saying, we're gonna increase the sedation so they can sleep tonight. So what are you doing? That's not how it works, right? It does not cause any kind of sleep activity, right? But it does great for seizure activity, right? Say, hey, I noticed some seizure activity. We're going to increase propofol for that seizure reasons. And we may not be able to get them off the sedation in the morning because of the seizure activities we saw tonight, right? So that'd be an appropriate conversation. So the dose is all 5s, except for the 10 that really irritated me when they changed it from, it was 5, 5, 5, 5, and then it was, then they changed the max to 75, and they then changed the frequency to 10. It's like, come on, guys. All right, so anyways, it's Q5. You can titrate by 5s, and up to 50 is what our max is at PRMC. When you start getting more than 50, you start getting more complications, right? One of the complications being PRIS, all right, or propofol-related infusion syndrome, right? So this is a consequence of a buildup of these triglycerides because it is fat soluble, so it's easy to get into tissues, including cardiac tissue. And this is where you hear some patients or some nurses or some providers say, I'm not going to give propofol at all because it's going to suppress their cardiac activity. It's going to cause bradycardia. That's not true. It only happens after like 2 to 3 days of high doses of propofol is when that's going to happen. Propofol is perfectly fine in a cardiac surgery patient or a cardiac patient or a bradycardic patient for that matter, right? It's when you start having high doses, right? Greater than 4 milligrams per kilogram per hour, which is a lot, right? Which is usually like more than 50 mics basically. If you're more than 40 to 50 mics for a prolonged use, like 24 hours, 48 hours, then that's where you're going to start getting this propofol-related infusion syndrome, or PRIS. And this is where it's going to start infiltrating all your tissues and start causing some problems, right? Yes, it can cause pancreatitis, but also can infiltrate tissues and make it so their metabolic pathways don't work good. So you start getting a metabolic acidosis that develops, right? So metabolic acidosis, an increase in your anion gap. So about 83% of patients will get that metabolic acidosis. So how do you know someone has metabolic acidosis? So the monitor rings up, metabolic acidosis. It's alerting. How do you know someone has metabolic acidosis? CO2 is going where? CO2 is not going up. It's going to be, we're talking about on chemistry, right? The CO2 or the bicarb, right, would be going down, right? So bicarb going down, or if we have an actual proper ABG, we can see our bicarbs getting low, and we can see our pH is low as well, less than 7.35. That tells us we're developing metabolic acidosis. Like, well, their sepsis is getting better. The white count's good. The procalcitonin is negative. I'm off pressors. What the heck? Why are they like this, right? Why are you the way you are, right? So that's also going to interrupt other processes as well, such as the heart function, right? So it's cause cardiac suppression, right? So you can see a little bit of decrease in ejection fraction. You can see some hypotension as well, but also you're going to start seeing some bradycardia develop. And that is with propofol-related infusion. All right, when they have a really high dose of propofol. So how do we avoid that? Well, we don't use high doses, right? That's kind of why 50 mics is our max, right? But even then, maybe it's like 50 mics for 5 days. That's going to start causing some propofol infusion syndrome, right? Also, another like pathognomonic reason why someone has PRIS is they have green urine. And what does pathognomonic mean? It means there's no other explanation. That means when you see this symptom or this problem, that is always this disease process, right? So green urine is always PRIS, right? There's no other reason for green urine. Well, green sputum is Pseudomonas, but I said urine, right? So green urine is not even if you drink that's what's it called? Slurp? What's it called for the 90s? Sludge. Not sludge. For the 90s, it was like a cool drink to drink.
Oh, Surge.
Surge, there it is. Surge energy or Surge soda, right? Even that's not going to cause your urine to turn green. Okay, so what else? So we've got hypotension. Every sedation causes hypotension. We know that, right? The bradycardia usually develops when they have this propofol infusion syndrome, and it's made from eggs. So it's people who are egg allergic, like anaphylaxis kind of thing, they then need to probably consider something else besides propofol. Even the Allergy Society says of America, like in 2021, says it's perfectly fine for someone with an egg allergy to get propofol, but we'll just be cautious about it, right? So it is lipid though, all right? It is a fat, so that means we have to change the tubing how often? Q12. Anything that has fat in it is always change Q12, whether it be propofol or be a lipid infusion for TPN or lipid amphotericin, right? Those all require a lipid, yes, a lipid infusion, but they are lipids, but it's also gonna be, the tubing needs to be changed every 12 hours, right? Because bacteria are going to love to bind to that tubing and puts you at more risk for infection. Okay, and we know it's a lipid, so it's going to start making you form more lipid storage, so it's going to make your triglycerides go up. So we got to monitor triglycerides, and if the triglycerides are greater than 500, it's definitely time to use something else, right? Because triglycerides greater than 500 put you at risk for pancreatitis. Technically greater than 1,000 puts you at risk for pancreatitis, but we're not going to play with it, right? So it's more than 500 on our triglycerides. We're going to then hold it and choose something else instead of propofol. All right, this is where you might see someone on benzos, right? Because they have a contraindication to propofol. Okay, so why don't we try Precedex? Well, they still have a high ICP, or they still have paralytic use, or they still have ventilator synchrony. So I need to be using something a little more heavy duty, right?
The triglycerides over, or should we be getting like regular triglycerides?
Yeah, at least every 3 days you should be in triglycerides, right? So day 3 propofol use, you want to get triglycerides, and it's like 200. Cool, we'll check it in 3 days. But the triglycerides are like 450. It's like I'm going to check it tomorrow, right? Okay. So we gotta trend the triglycerides. Okay, so each one of these pages has a list of all the sedatives, just like when we went over pressors, right? So here's our propofol right here, right? There's our Precedex we talked about already, right? And Versed and Benzos will be coming to, and we'll finish off with opiates. So just so as you can see all the information on each page, all right? All what we're talking about as far as the differences between the sedatives, right? So as you know, propofol, yes, can lead to PRIS. It can lead to, does it cause delirium? Yeah, but does it cause delirium independently compared to everything else? That's what benzos are known for, right? And it has a very, very short half-life, right? Really, if someone has hepatic failure or renal failure, you don't really have to adjust the dosages that much, right? And it can cause a reaction if they have an egg allergy or soy allergy. Notice the previous slide had no pain. This one also has no pain. These are what medications? These are benzos. And the benzos we use IV push, or IV, so I should say IV infusion, or midazolam and lorazepam, right? So like Valium, for instance, is yes a benzo, but it's not usually given as an IV drip, right? As a drip from pharmacy. All right, so we got lorazepam and we got midazolam. And midazolam is preferred over lorazepam, and we'll mention why in certain situations, such as like status epilepticus. Ativan is preferred, right? Someone has a alcohol withdrawal, then Ativan will be is better efficacy compared to midazolam. Does midazolam also inhibit those pathways? Does it also help alcohol withdrawal and help seizures? Yes, but it's better to use Ativan if we can, right? So again, higher risk of delirium and accumulates in fatty tissues, so that's why it's not great for someone that's we just want to quickly get them off the ventilator. Usually it's one of our not top shelf but bottom shelf items that will pull out if they don't meet criteria for propofol, right? They're still sick and they still have seizure activity, they still have problems that we need to address, and we can't utilize propofol, for instance, because the triglycerides are super high. Okay, so it accumulates in renal failure and in fat failure when they have fat buildup as well. All right, it is beneficial with seizure activity, E2H withdrawal. Phenobarb is the preferred agent for patients like PRN pushes of phenobarb, and we'll talk about that more, I think, in neuro for anti-alcohol treatment. Okay, all right. So contraindications are really the reason why we are using benzos in the first place, right? We tried everything else, and now we're gonna succumb. What's the word? We're going to allow benzos to be used at this point, right? So initial rates, they're a dose per kilo. All right, 0.02 is what you started at. Max it to 0.025. All right, that should be 0.25 probably, right? That doesn't make sense. 0.02. Yeah, it does. Anyways, we should be at 0.25. All right, so we should, then again, the default, this is the default orders that are on, that come from corporate, right? If they do have seizure activity, we are going to, or status epilepticus, continuous seizures, that is going to be a max of 0.6, which is a lot higher than 0.25, right? What else? We got lorazepam. So lorazepam is just like midazolam, except it's much, much thicker, right? So it's as thick as oatmeal, right? So Ativan is very, very thick when you give it, when you draw it up. If you imagine giving a whole bag of it, it's like giving honey to a patient, right? So it has a longer, thicker half-life as well. So it's going to stick around for a lot longer, and that thickness is from the solvent that the Ativan is dissolved into to make it so that you can actually give it as liquid form, right? That's called propylene glycol. And by that same token, this is why they always tell you don't give more than this amount of Ativan in 24 hours. Don't give too much of it, otherwise you'll develop propylene glycol toxicity, right? And then that's again a metabolic acidosis that develops, right? So if we get a metabolic acidosis for PRIS, we also get a metabolic acidosis for too much lorazepam infusion, right? It doesn't happen with midazolam because midazolam is not super thick like that. It's not mixed in propylene glycol. Okay, so you get this metabolic acidosis that will develop from lorazepam infusions. And why would you need lorazepam? It's preferred over someone with seizure activity or someone with alcohol withdrawal. Okay, so you can see that Ativan lasts longer, and it's great for seizures because it's going to last and it's going to hopefully abate the seizure for a certain period of time until you can get them on some proper anti-seizure medications like Keppra or Dilantin or something. Okay, and usually if someone's requiring more than 4 milligrams, like 6 milligrams, that's going to start causing respiratory depression. Usually you're safe up to giving like 4 milligrams of Ativan, of lorazepam. Okay, so that's our idea with our benzos. They're blocking the GABA receptor just like our propofol is, right? But it also has other untoward side effects such as delirium, and of course our Ativan can cause a propylene glycol toxicity.